Greetings everyone. Thank you for joining me today. I am Nathawan, second year in-service training resident. I'm glad to present you today ADL video topics. Pharmacologic management of chronic neuropathic pain, quoting reference from Canadian Family Physicians, issued November 2017. Also a review of Canadian Pain Society consensus statement. First of all, to discuss neuropathic pain, definitions is crucial, and also another pain region or domain that we have to consider. We all know classifications of the pain according to management. Today we are going to focus solely on neuropathic pain. Neuropathic pain considers to be lesions or disease of somatosensory system. For common example, post-herpetic neuralgia and painful diabetic neuropathy. Goals of treatment in neuropathic pain is to improve quality of life, a sleep pattern to improve social integrity, that one can socialize with another pain-free. Considering treatment to be successful, pain should be reduced by 20–30%, more than just accessing visual analog scale or numeric pain score. The guideline covers the algorithm of pharmacologic management, that to be choose the first, second, third, and fourth line agents accordingly, and also can come up with combination if the pain is inadequately controlled or partially controlled, as we will cover in the upcoming slides. To show you here is a tool to assess whether a pain is neuropathic component or not. Is the ID pain question and scoring is a tool for self-report patients. If the patient have more than one area they can considering to be area of most relevant to the answer is most painful area. It is a self-report for the patient to report his pain character. Score range from -1 to 5. The higher the score is the more likely the pain is to be neuropathic. Moving on to the first line drugs. There is the three classes of drugs that's considered to be the first line to manage neuropathic pain. First one is the Gabapentin or Gabapentinoid class of anticonvulsants, Tricyclic antidepressants, and SNRIs or Serotonin-norepinephrine reuptake inhibitors. Gabapentinoids, the most common we use is Gabapentin and pregabalin. Gabapentin is effective against post-herpetic neuralgia, and pregabalin can be used against chronic central neuropathic pain after spinal cord injury. The central stroke pain. Another effect for pregabalin is improved sleep and reduced anxiety also. The third one in this group is carbamazepine, effective solely for idiopathic trigeminal neuralgia. This group considered to be start with low dose and slow titration, especially in elderly, coming along with the side effect of sedation, dizziness, edema, and weight gain. Good thing they don't mess around with hepatic enzymes, so people with hepatic impairment can be used. But as I emphasized, the pregabalin needs renal dose adjustment. For the dosage, gabapentin initial dose of 100 to 300 milligrams per day. To try trade up 100 to 300 milligrams per day every week until achieve pain control. Maximum dose to be 1200 milligrams 3 times daily. Adverse event, as I discussed earlier, also dose adjustment of both gabapentin and pregabalin. Pregabalin initial dose is to be 25 to 150 milligrams per day. Titration up by 25 to 150 milligrams per day every week. Dosing range up to 3 milligrams twice daily. As you can see, gabapentin defines itself in 3 times, but pregabalin can be used twice daily because of the pharmacodynamics of the drugs and the half-life of pregabalin to be used longer. Carbamazepine, initial dose is 100 mg. Titration by 100 to 200 mg per day every week. Maximum dose is 400 mg 3 times per day. The information of renal dose is provided by the drug company. Recommend dose adjustment based on the renal impairment degrees. As you can see, the dose to be adjusted accordingly to the creatinine clearance. First-line agent, also TCAs, can be used in various neuropathic conditions as post-herpetic neuralgia. Considering of the side effects, nortriptyline is less found to be adverse event than amitriptyline and imipramine, are a little bit safer to be used. The side effects are less sedations, postural hypotension, anticholinergic effects. Also, starting with a loaded dose also decrease the side effect. Titrate slowly is another wise technique to use. Suggestion to be used in early evening, so we achieve the sedation in the night as the byproducts of the drug. The TCA also warning itself to be used in elderly with extreme caution, as it can cause cognitive impairment, increased risk of fall, accordingly to American Geriatric Society, Beer's criteria 2015, and V2 stop and start criteria. I will also put the links of these to reference in the comment. Dose above 100 mg per day of any TCAs increased risk of myocardial infarctions and tachycardias. By the recommendation of Neuropathic Pain Special Interest Group, also an organization focused on neuropathic pain, the age of the patient above 40 years, the history of cardiovascular disease, the risk of certain cardiac death, warrant the baseline EKG before the start of TCA. The dosage of TCAs is starting with 10 to 25 mg per day. Titrate up by 10 mg per day every week, maximum dose of 100 mg per day. As we already discussed, as you can see, the anticholinergic effects along with arrhythmia for the risk of MI, especially in elderly, of course. The first-line drugs, SNRI, is the third group that recommend to be used. Two drugs that proven by clinical trial to be effective is duloxetine and high-dose venlafaxine. Duloxetine is effective against chemotherapy-induced painful neuropathy, and high-dose venlafaxine is effective against mixed painful polyneuropathy. Common side effects is nausea, tachycardia, elevated blood pressure, and GI side effects, as could to be from venlafaxine, and hepatotoxicity, as could to be from duloxetine. The dosage of venlafaxine is starting with 37.5 mg per day, increase 37.5 every week. Maximum is to be 150 to 225 mg per day. Also, we have GI side effect, dizziness, and hypertension for venlafaxine. Also, venlafaxine needs renal dose adjust. Duloxetine start with 30 mg per day, increased by 30 mg per day every week, maximum dose of 60 mg per day. As the statement also discussed that the dose above 60 mg show no benefits in clinical trial, and to be avoid using duloxetine in hepatic insufficiency and renal impairment patient. The second-line drugs for neuropathic pain is opioids. The example we use is tramadol is effective for diabetic neuropathy and mixed neuropathic pain syndrome. Side effect, as we all know of the common of opioid, especially for tramadol, itself can reduce seizure threshold and the risk of serotonin syndrome if tramadol is used along with SNRI and SSRI. Common consideration of using opioid is tolerance. If patient become tolerant to opioids, we have to do some rotation. More dose may need to be achieved pain. Long-term use of opioid may induce hyperalgesia. The dosage of tramadol initial dose to be 50 mg per day, increased by 50 mg per day every week. Dosing range of 50 to 100 mg 4 times a day, or 100 to 100 mg per day for controlled release. Adverse events, as discussed earlier, also include orthostatic hypertension, ataxia. It might lower seizure threshold to mention again, and to use with caution in patients with epilepsy. Morphine, oxycodone, fentanyl, and hydromorphone can be used also. The third-line drugs of neuropathic pain pharmacologic management include cannabinoids. Cannabinoid is effective against neuropathic pain in HIV, diabetic neuropathy, post-traumatic, and post-surgical neuropathic pain, mixed central and peripheral neuropathic pain states. To mention by the guideline is the patient needs to be 25 years or above. There is no risk of pregnancy, no history of cardiovascular disease or respiratory system disease, no history of psychosis or substance abuse disorder. The drug needs to be off if there is no clear benefits of using it or confirmed to be harmful. In Thailand, it is illegal still to use cannabinoid. I want to discuss more about Thai laws, as the news ravaging across the country of cannabinoid can be used medically. Can it be used medically now? Cannabinoid is available in Canada in the form of nabilone and nabiximols, as in Thai still some degrees of barriers for patients to access to the drugs, and is still not approved by Thai FDA. The fourth-line drugs, the SSRI, fluoxetines, effectively against painful diabetic neuropathy. Painful polyneuropathy and risk of serotonin syndrome needs to be addressed. Also, is a contraindications to be used along with monoamine oxidase inhibitor or MAO-I. Also, a choice to be used by local drugs, as I present you the lidocaine topical patch or gels. It is the second line for post-herpetic neuralgia. Says the systemic side effects is rare. It's easy, right, to manage neuropathic pain by drugs. We use the first line drugs, one of the three groups, Gabapentinoids, TCAs, or SNRIs, and then if it's not adequately improve the pain, we add another one is by adding the first line drugs by the other groups or adding tramadols. If it can be used effectively enough, cannabinoid is the third line drugs, also not available in Thai, and the fourth line drugs, it might have to be very careful if we use tramadols also, because it is toxic by the combination we might have beat the neuropathic pain itself. For take-home message, I want to address of the goal of treatment from earlier slide, as the pain have to reduce by 20 to 30% or 1/4 of the pain in origin from the start, as we focus on the patient quality of life and social and functions of his own, the social function of the patient. The take-home message for the take-home message of this slide and for the take-home message of this presentation, I want to address again of the combination use of the drugs, as the clinical trials and the guidelines also conclude that using just solely one drugs might not be enough pain relief for the patients. Combination is also the key to beating neuropathic pain. As a goal, we also have to remind ourselves of the patient life, to to caring him for the whole person of quality of life, social functions, and the pain reduction. Whether the cause of the lesion in neurological or somatosensory system is. For reflections of this topic ADLs, I want to give the idea of mine is kind of thinking ahead before facing true neuropathic pain patient. Me still doesn't have a lot of parents. My reflections of this ADL video is the first English. Oh no, My reflections of this ADL video is solely neuropathic pain discussions, as the patient with neuropathic pain is common, and it might not be just neuropathic pain, or it might be the mix between somatic pain, nociceptive pain, along with neuropathic pain. We all have to altogether treat the pain. So knowledge is individual, essential. My feelings is a little bit nervous by the fact that this is the first ADL video that I decided to make in English by the inspirations of visiting my elective in Hat Yai, Songkhla. The PSU medicine family medicine department, they also give English conference, so I decided to try one, and feeling a little bit nervous. And the function is, I can say that I did it not 100% perfect, and yes, it is not, but I've tried. So my expectation is to welcome every comment from the respect from our staff and fellow residents. Feel free to comment, and I will take every comment as the motivation to improve my future ADLs. Up to this point, I'm very grateful that you have listened. Or up to this point, I have to present my gratitude of everyone participating in listening and discussions of these videos. Thank you.